Okay, so hi, evening friends, evening everybody, bache. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And let us have our last rapid revision 200 par high yield questions for the FMGE 2023 exam. Now, before we even go further, what is the target of this session? I'll be writing less stuff. I'll be speaking more. So listen to this session very attentively. You are going to have, I'll keep it as a short, sweet, maximum 50 minutes to 1 hour session. And you are going to have minimum of 12 to 15 questions from this session. So, bache, let us start. Let us start. And I love this name also, Never Give Up and Dopamine. Bache, let us start with our content. Starting with oncohematology or blood cancers. I have kept this in the beginning because every paper you get 2 to 3 questions and we tend to get confused also. So child with acute leukemia, diagnosis, keep on telling me the answers side by side. I will be giving you the PDF at the end of the session also, so absolutely don't worry about anything. Just keep your mind focused and keep on telling the answers. Child with acute leukemia, ALL. Which ALL? BLL. Versus adult with acute leukemia, AML. Adult with acute leukemia, AML. Now, adult with high TLC, TLC is high 1,20,000 TLC with splenomegaly, with presence of all the cells, that is with blasts, promyelocyte, myelocyte, metamyelocyte, eosinophils, basophils, everything is there. Diagnosis, CML, chronic myeloid leukemia. So, child with acute leukemia is ALL, adult with acute leukemia, AML. Adult with high TLC with presence of all the cells, CML. Chronic myeloid leukemia, CML, translocation, 922, also called as Philadelphia chromosome. Protein formed, BCR ABL. Protein BCR ABL. CML, good prognosis, poor prognosis? Good prognosis. Why? Because we have therapy against CML, that is imatinib, trade name Celiac. We use the first line TKIs, tyrosine kinase inhibitors, imatinib or Celiac. Next, presence of an adult with high TLC. TLC is high with presence of smudge cells. The minute you see smudge cells on peripheral smear, diagnosis CLL, chronic lymphocytic leukemia, CLL. And lastly is a child with acute leukemia. What should have been the diagnosis? BLL. Child with acute leukemia with presence of a mediastinal mass. Which are the two magical words in this statement? Mediastinal mass, TLL. If you know these, this takes care of theory part of at least 8 to 9 previous year questions asked in the previous 1.5 2 years only. Next, diagnosis. Dekho bache, this is of course peripheral smear. As compared to an RBC, you see the presence of very large cells, 2.5 to 3 times the size of an RBC with odd rods. Characteristic feature of presence of a myeloblast is odd rod. तो जैसे हमें ऑड रॉड नजर आएगी, when we will see odd rods, it is a myeloblast, AML. But this AML is special. It shows the presence of multiple odd rods. It has multiple odd rods, as you are clearly able to see. Cells with multiple odd rods are called as faggot cells, seen in AML M3. Also called as acute promyelocytic leukemia, AML M3. Called as acute promyelocytic leukemia, AML-M3. Translocation 1517. Protein formed, PML rara. I'm again stressing all these are the questions that we need to know. Easy to remember. देखो हम Punjabis हैं ना. So when we are happy we do rara. So PML rara. It is the best prognostic AML, AML-M3. It is best prognosis. Which is the most common cause of death in M3? DIC. So I can rephrase this as DIC is most common in which AML? AML M3. Next, this was last year FMG exam question. Exactly this image was given. Next, I guess examiner's favorite question, including this December FMG 22, and going wrong in this question will be a blunder. Elderly male with multiple lytic lesions in the hip, serum calcium is increased. Diagnosis. The minute the examiner is talking of plasma cells, increased number of plasma cells with any one graph features, diagnosis multiple myeloma. Previous 3 papers, Every previous 3 years, every year has 2 exams, 6 papers, close to 13 questions have been asked from multiple myeloma. So listen to this carefully. Plasma cells with any one graph features. Calcium is increased, renal insufficiency, anemia, bone lytic lesions. Any one graph features, calcium is increased, are which organ? Renal. Renal insufficiency, anemia, bone lytic lesions, multiple myeloma. Next, which is the most common immunoglobulin in multiple myeloma? IgG. Which is the most common protein increased in multiple myeloma? Gamma globulins. In urine, it is associated with presence of Benz-Jones proteinuria. It is associated with Benz-Jones proteinuria. Multiple lytic lesions in the skull. Next, it has 2 bodies. This has not been asked till now, so I will not be astonished if you get this question in this your FMGE exam. That is Dutcher bodies and Russell bodies. Easy to remember, bache. Dutcher, DNA. So Dutcher bodies are intranuclear versus Russell bodies which are intracytoplasmic in nature. Which are intracytoplasmic. Multiple myeloma. On protein electrophoresis, it shows the presence of an M band. M stands for monoclonal band. Now, this question, the one that we are discussing, was asked this time in your December 2022 paper, and this was the image that was given to you. Examiner told you that it is peripheral smear. RBCs are stacked up on each other, that is, it is associated with rouleau formation. And as compared, I guess slight spelling error in rouleau, and as compared to the RBC, you see, just a sec, we have rouleau formation, and as compared to an RBC, you see the presence of very large cells, abundant cytoplasm, eccentric nucleus. Cells are very large, there is a lot of cytoplasm and an eccentric nucleus. This is what plasma cells look like. So diagnosis, answer, these are your 4 options, 1, 2, 3, 4. Diagnosis, majority of the students marked it as multiple myeloma. Nahi bache, it was a case of plasma cell leukemia. Why? Because if there are more than 20% plasma cells in peripheral blood, dekho, this is peripheral blood, all these are plasma cells only, they are more than 20%. More than 20% plasma cells in peripheral blood makes it as plasma cell leukemia. So if plasma cell leukemia was not given in this question, then the answer would have been multiple myeloma, otherwise plasma cell leukemia. Next question, answer. Now, middle-aged adult with splenomegaly, high TLC with presence of myeloblast, promyelocyte, myelocyte and basophils. All the cells are present. Diagnosis, CML. Diagnosis, CML, we have already seen that with hepatosplenomegaly. First class. Asha, now before we go further, tell me 2-3 points more. Now, suppose you are given translocation 1418. Translocation 1418, answer, follicular lymphoma. Versus translocation 1114, mantle cell lymphoma. 1114, mantle cell lymphoma. Follicular lymphoma, protein expression, BCL2. It is BCL2 positive. Versus mantle cell, which is BCL1 and cyclin D1 positive. It is BCL1 and cyclin D1 positive. These are the other translocations associated. Next, so this takes care of oncohematoblood cancers, main points. Acha, Burkitt's lymphoma, translocation 814. Gene mutation, c-MYC, which is a proto-oncogene. c-MYC, proto-oncogene mutation, translocation 814, Burkitt's, starry sky appearance. Done. This takes care of blood cancers. This gets us to thyroid. Which is the most common thyroid malignancy? These are the most commonly asked high yield points. You need to know them. After thyroid, we will go to CNS and so on. Most common thyroid malignancy, papillary thyroid carcinoma, PTC, followed by follicular carcinoma thyroid. Most common is papillary followed by follicular. What is the diagnostic hallmark of PTC? Papillary thyroid carcinoma microscopically shows orphan annii nucleus. Annie, she was a cartoon character of 1980s who had a face like this. She had large clear eyes. So she was an orphan. Orphan annii nucleus seen in papillary carcinoma thyroid. Next question. Investigation of choice for thyroid lesions. TSH, radioactive iodine uptake, FNAC. Screening test is TSH. Investigation of choice, FNAC. FNAC is useful in all the thyroid lesions except follicular neoplasms. We cannot differentiate follicular adenoma from carcinoma. So FNAC is useful in all except follicular neoplasms. Next, which is the thyroid cancer associated with amyloid? That is medullary carcinoma thyroid. Associated with amyloid, medullary carcinoma thyroid. And which amyloid is getting deposited in that? That is ACAL, amyloid calcitonin, ACAL. Lastly, most common cause of thyrotoxicosis. Thyrotoxicosis is increased T3 or T4. Most common cause of thyrotoxicosis with hyperthyroidism, that is Graves' disease. Graves' disease as a result shows the presence of thyroid stimulating a thyroid inhibitory antibody. Thyroid stimulating, long acting thyroid stimulating antibody. It has IgG LATs, long acting thyroid stimulating antibody. Making Graves' disease as which hypersensitivity? Recent FMG questions only. Making Graves' disease as, देखो बच्चे, antibody mediated hypersensitivity. But there are only two diseases with type 5 hypersensitivity. Graves' disease and myasthenia gravis. Type 5, that is the best answer. If 5 is not given in the options, followed by a type 2 hypersensitivity. This is with respect to thyroid. Next, let's see few highly yield points about CNS tumors. Most common CNS tumor, I want you to tell me this. Most common CNS tumor, metastasis. Please do not forget metastasis. Put a line on the side. Mets are most common. Metastasis, they are the most common in lungs, liver, heart, brain and bones. The most common primary tumor at these sites, lung, liver, heart, brain and bones, is metastasis. Which is the most common primary site? Most common primary site for lung cancer. What is above lungs? Breast. So most common primary site being breast cancer. Which is the most common primary site for liver metastasis? In the liver, metastasis comes from the intestine. That is colonic adenocarcinoma. Liver, colonic adenocarcinoma. Versus heart. Heart is surrounded from all the sides by lungs. That is lung cancer followed by breast cancer. Lung cancer followed by breast cancer. Again, an important high yield point, metastasis, they are the most common at these sites. Now coming back to CNS tumors, Paras, totally agreed those, totally agreed. We'll add bones to your list. Now, most common CNS tumor was metastasis, most common primary CNS tumor being meningioma. Most common primary CNS tumor, meningioma. Meningiomas followed by gliomas. देखो बच्चे, in your FMG exam, you always go for most common. This question itself has been asked twice in your FMG exam, including this December FMG. A young female presenting with dural mass and frontal headache. CTs, MRIs was given to you, microscopy was given. What will be the microscopic feature? It was given as written MCQ. Meningioma shows whirling. And it is also associated with calcifications. What is the fancy name of calcification seen in meningioma? It is calcifications in tumors called as semoma bodies. They are called as semoma bodies. So most common primary CNS tumor, meningioma followed by gliomas. Next, most common primary malignant CNS tumor. Primary malignant CNS tumor in children is medulloblastoma. Medulloblastoma versus adults, that is glioblastoma multiforme. Versus adults, that is glioblastoma multiforme. And lastly, most common primary CNS tumor. Acha, tell me this, suppose in children was not written. Most common primary CNS tumor, meningioma. Most common primary CNS tumor in children is pilocytic astrocytoma. Pilocytic astrocytoma. See, it is occurring in children. Let's have a soft heart for kids. It's a WHO grade 1 CNS tumor. Let's have a soft heart. Bahubali has taught us this is how we hold a child. So most common location, cerebellum, pilocytic astrocytoma. Acha, tell me one more point. Medulloblastoma and glioblastoma multiforme, they are which grade CNS tumor? They are malignant now, so they are WHO grade 4 CNS tumors. This is with respect to CNS. Next, this gets us to our fourth important topic, that is kidney. But again, every paper you get 2-3 questions in kidney. So that is why I'm stressing for all of you, you must see this session once again. We can divide the glomerular disease into nephrotic and nephritic syndromes. Examiner will give you the history of a child presenting to your OPD with grade 3 proteinuria. Grade 3 proteinuria is massive proteinuria more than 3.5 grams per day. There is protein loss. So hypoalbuminemia, edema, hyperlipidemia and lipiduria. Versus nephritic, that is mild proteinuria, hypertension and hematuria. Instead of writing hematuria, they write it as cola-colored urine. So first thing that you have to see is whether this is a case of nephrotic versus nephritic syndrome. Which are the nephrotic syndromes? They are MCD, minimal change disease, MGN, membranous glomerulonephritis, MPGN, membranoproliferative glomerulonephritis, and FSGS, focal segmental glomerulosclerosis, versus nephritic being PSGN, post-streptococcal glomerulonephritis, PSGN, IgA nephropathy or Buerger's disease, and RPGN, rapidly progressive glomerulonephritis, also called as crycentric glomerulonephritis. First point, agreed, KK bang on right. Most common nephrotic syndrome in children, MCD. So those, the minute you are given a history of nephrotic syndrome in a child, minimal change disease. Versus if you are given a history of hypertension, proteinuria, that is cola-colored urine, occurring 1 to 2 weeks after respiratory tract infection. Diagnosis, PSGN. So most common nephritic syndrome in children, occurring 1 to 2 weeks after respiratory tract infection, that is PSGN. Whereas nephritic syndrome occurring in adults 1 to 2 days after respiratory tract infection, being IgA nephropathy. This is nephrotic versus nephritic. Now think of it yourself. Most common nephrotic syndrome in children, MCD, minimal change disease. So let's have a soft heart for kids. MCD, it is good prognosis, has dramatic response to steroids. That is, it is steroid responsive. So tell me this, a 5-year-old child with periorbital edema and electron microscopy shows diffuse effacement of food processes of podocytes, MCD. Child with nephrotic syndrome with effacement of food processes of podocytes, MCD, minimal change disease. Versus, now have a look at this electron microscopic image. The minute I see this, I am clearly able to make out this is electron microscopy showing the presence of glomerular basement membrane. This is GBM and these are the food processes of podocytes. This is normal. Versus the second image shows, this is glomerular basement membrane, it shows diffuse effacement or loss of food processes of podocytes. That is MCD, minimal change disease, MCD. Next, child with hematuria and presence of RBC-CAS, making it as PSGN, post-streptococcal glomerulonephritis, occurring 1 to 2 weeks after respiratory tract infection, cola-colored urine. We have already seen that. On immunofluorescence, it has the classical starry sky appearance. Starry sky appearance in kidney is seen in PSGN. In blood cancers, in lymph node biopsy, starry sky appearance is seen in Burkitt's lymphoma. Again, बच्चे पूछा जाता है, this is again asked. Kidney PSGN, lymph node biopsy, Burkitt's lymphoma. Next question. Asha, now this was this time's NEET PG question, a written MCQ, so it can again be asked in your paper. Both MGN and PSGN have a subepithelial deposit. Both of them, both MGN and PSGN have a subepithelial deposit. Firstly, Next, the special name of deposit seen in MGN is spikes. Spikes are seen in MGN versus humps, which are seen in PSGN. Both are subepithelial in nature. And on electron microscopy, this is what it looks like. देखो बच्चे, this is glomerular basomembrane, this is the GBM. The minute you see the presence of this elevated thing, that is, it looks like a hump. Humps are seen in PSGN. Humps are seen in PSGN. Next, diagnosis. Asha, again, before I go further, tell me the answer to this question, and I want all of you to tell me this. Child presenting with hypertension and presence of cola-colored urine 1 to 2 weeks after respiratory tract infection. At admission, his creatinine levels are 2.4. What is the diagnosis? PSGN. Child with nephritic syndrome, PSGN. Therapy was started, and 10 days after therapy, when creatinine was evaluated, it was found to be 5.2. Which of the following will be the light microscopic feature? Now tell me this. It was a case of PSGN, which after therapy also, creatinine levels doubled within 10 days. Diagnosis, RPGN, rapidly progressive glomerulonephritis or crescentic glomerulonephritis. So what will be the light microscopic feature? Presence of crescents. And this is what? Humble nahi dost, it was not PSGN. It was initially a diagnosis of PSGN. Paras nahi dost, it was initially PSGN which progressed to RPGN. So what will microscopy show? Crescents. This is what it looks like. You see the presence of a glomerulus in which capillaries are pushed to one side with presence of crescent on the outside. Crescentic glomerulus. Next, so this takes care of glomerular diseases and gets us to blood vessels. Now, a very straightforward image. Let's first start with gross. You are able to see these hemorrhagic spots on the skin. The BP was very high, so capillaries rupture on the renal capsule, giving it the classical flea-bitten appearance. Microscopically, we are able to make out that this is a blood vessel. It has RBCs in the lumen, but the vessel wall is disintegrated with fibrin-like material, fibrinoid necrosis. So now combine the two together. That is flea-bitten appearance with fibrinoid necrosis, malignant hypertension. But which is more specific with malignant hypertension? Fibrinoid necrosis, yeah, onion skin appearance. This is the onion skin appearance. The BP was very high, so the muscle layer undergoes concentric hyperplasia, onion skin appearance, which is characteristic, more characteristic, onion skin appearance, because flea-bitten appearance is seen in many other conditions also. Which are the other diseases with flea-bitten appearance? They are malignant hypertension, of course, SLE, RHD, rheumatic heart disease. Which vasculitis? PAN, polyarteritis nodosa, PAN, and graft rejection, hyperacute type. These are the other diseases with flea-bitten appearance. So more characteristic, onion skin appearance. Lastly, coming on to urine examination, stones and casts. Starting first with urolithiasis, which is the most common renal stone? Calcium oxalate, written recent MCQ, showing the presence of envelope-shaped crystals. Calcium oxalate. I am not interested in telling you that calcium oxalate monohydrate is dumbbell-shaped, dihydrate is envelope-shaped. Fair enough. Next, second image. You are clearly able to see that this is what prisms look like. These are the 3 to 6 sided prisms or coffin lid appearance. 3 to 6 sided prisms or coffin lid appearance seen in triple phosphate. Next, triple phosphate stones, they are associated with which infection? Proteus. They are the largest of all renal stones, meaning they occur in renal pelvis. From the renal pelvis, when they go to the calyces, it looks like horns of a stag. So staghorn calculi, triple phosphate. Next, this is plain simple rhomboid crystals seen in uric acid, and lastly hexagonal laminated appearance, that is cystine stones. Hexagonal laminated appearance, cystine. This is urolithiasis. And coming to urinary cas. Urinary cas was a new topic which was introduced in this December FMG. So bache, chances of this being repeated is again very high. Urinary cas, which is the most common urinary cast? Most common being hyaline cast, which is composed of TAM phosphoprotein, can be seen normally also. TAM phosphoprotein can be normal. Next is RBC cast. Why will RBC come into urine? Because of glomerulonephritis. RBC casts are seen in glomerulonephritis. Versus WBC casts, which are seen in infections, that is pyelonephritis. WBC casts, pyelonephritis. Simple, nothing is to be rectified. Most common hyaline cast, agreed. Humble agreed. Most common hyaline cast, TAM phosphoprotein. RBC cast, glomerulonephritis. WBC cast, pyelonephritis. Granular casts, let me write it on the side here. Granular casts are seen in ischemias. Versus broad casts. Put a star, very, very important. Broad cast. Dekho, the minute the word broad is written, examiner can write broad granular cast or broadcast. जब तक broad लिखा है, broadcast, I always remember it as the renal tubules have become dilated. They are broad. Seen in chronic renal failure. Seen in chronic renal failure. This is with respect to urolithiasis and urinary casts. So this finishes kidney. And this gets us to our next important topic, vasculitis. In this high yield section, I am again saying I have chosen the topics which always you get questions in your paper. So everybody bache. 60 male with throbbing headache, nodular thickening of the temporal artery. Just touch your temporal artery once, just touch your forehead once and you will never go wrong in it. Microscopically it has giant cells and granulomas, giant cell arteritis. Seen in elderly, more than 50 years of age. Tuk-tuk are the pulses. So Takayasu syndrome is pulseless disease. So if you have a history of a 38-year male, pulseless disease with feeble femoral artery or feeble radial pulses, diagnosis Takayasu syndrome. Tuk-tuk are the pulses. Takayasu syndrome age group is less than 50 years of age. Which is the most common vessel affected? Arch of aorta and left subclavian. The above vessels are affected, so the left radial pulse is absent. Arch of aorta and left subclavian. Next, HSP, Hinock-Schönlein purpura. HSP, it is the most common vasculitis in children. Child presenting with colicky abdominal pain and purpura. Child with colicky abdominal pain and purpura. That is HSP, Hinock-Schönlein purpura. In dengue, purpura is hemorrhagic spots on skin. In dengue infection, purpura is occurring because of low platelet count. In HSP, purpura is occurring because of vasculitis. And lastly, Buerger's disease. It is the most common vasculitis associated with smoking. And so clinically, which are the vessels affected? The peripheral vessels, radial and tibial. So clinically, it is associated with intermittent claudication. That is pain while walking. These are the vasculitis. Let's have a look at another vasculitis question. Child with abdominal pain, rashes and arthritis. Which vasculitis? HSP, Hinock-Schönlein purpura, HSP. Next. Female went camping and had bee sting injury. A favorite examiner question. I think previous 4 papers, you each one question each from type 1 hypersensitivity. Bee sting injury resulting in edema, redness and difficulty. This is type 1 hypersensitivity, IgE mediated response. Which is the main cell of type 1 hypersensitivity? Main cell of type 1 hypersensitivity, mast cells. Followed by eosinophils, basophils and T cells. So again an FMG question, cell in type 1 hypersensitivity is answer to be marked was T cells, others were not in the option. Stain used for mast cells. Stain used toluidine blue. Stain used for mast cells, toluidine blue. Main activator of eosinophils, E is the fifth alphabet na, 5 followed by 4 versus basophils, 3 followed by 4. Type 1 hypersensitivity. Overall, next another FMG question, same thing. Child was having seafood allergy leading to anaphylaxis like reaction. Main mediator, histamine. Main mediator, histamine. Overall, I want you to write this and tell me which is the main cytokine associated with type 1 hypersensitivity. Interleukin 2, 3, 4, 5, 6. These are your 4, 5 options. In which one? Interleukin 2, 3, 4, 5 or 6? Which interleukin 5? Why? Which is the main leukocyte increasing in peripheral blood? Eosinophil. Which is the main activator of eosinophil? Interleukin 5. E is the fifth alphabet, interleukin 5. That was with respect to type 1 hypersensitivity. 3-4 questions, this slide, previous 2-3 papers. Next, again a slide, 3-4 questions in previous 2 years only. 25 male, malabsorption, diarrhea, villus atrophy. Diagnosis, the minute anybody talks of villus atrophy, diagnosis is celiac disease. This was last year's written question. Before that, they had given an image also. I'll show it to you. So, celiac disease, antibody, anti-endomysial, anti-gliadin, and anti-transglutaminase antibody. Celiac disease. What all the patient cannot eat? He cannot eat wheat, rye, oats, barley. Some people remember it as bro also. We eat wheat, rye, oats, barley. Skin lesion associated with celiac, DH. Dermatitis herpetiformis, skin lesion associated, DH, dermatitis herpetiformis. HLA alleles associated, HLA DQ2/DQ8, celiac. And microscopically, now have a look at this image. What we see on the left side are villi and crypts. What is going on up is a villi, what is coming down is a crypt. This is normal. This is normal. Versus celiac disease, which has flattening of villi with crypt hyperplasia. So total thickness is maintained. This is celiac. This is celiac. Next point. Now celiac has been asked so many times that if examiner wants to go a step further, he can talk about Whipple's disease. There's a very high probability of Whipple's being asked in this exam. Whipple's shows the presence of PAS positive diastase resistant granules. Whipple's disease, periodic acid shift positive diastase resistant granules, where in macrophages, most common location of which is lamina propria. Most common location is lamina propria. This is Whipple's. Everybody, bache, please give me a thumbs up or like the video if you are comfortable with all the points that we have discussed till now. Everybody, so that I know that you are able to comprehend also. Next, recent question. Young child with skin rash. I need not even tell you that this is the butterfly-like rash associated with SLE. Antibody, ANA. Anti-nuclear antibody. So, which is the most common antibody with SLE? Most common antibody associated with SLE, ANA, anti-nuclear antibody, versus most specific. S for specific, S for Smith, anti-Smith, followed by anti-double stranded DNA antibody, followed by anti-dsDNA. Next, neonatal lupus with congenital heart block. Neonatal lupus with congenital heart block. Answer, anti-Rho/LA antibody. देखो, I always remember it as neonate है ना, neonate cries. रोला पाता है for the Punjabis or Hindi speaking, रोला पा रहा है. Neonatal lupus with congenital heart block, Rho/LA, also called as SSA/SSB antibodies. And lastly, drug-induced lupus. Antihistone antibody. Drug-induced lupus, antihistone antibody. So these are the antibodies associated with SLE. Next question. Vegetarian patient, peripheral smear is given to you. What do you see in this peripheral smear? Forget vegetarian. I mean, examiner gave you both the hints. He gave you that he is a vegetarian. So which vitamin is present only in meat? Vitamin B12, megaloblastic anemia. As such, you are able to see a hypersegmented neutrophil with 6 lobes. More than 5 lobes in a neutrophil, hypersegmented neutrophil, which is the first feature of megaloblastic anemia on peripheral smear. But certainly, let us talk about men syndromes. Now that you have asked me about men, let us talk with respect to men syndromes. Men, those are of 3 types: men 1, men 2A, men 2B. Men 1 is also called as Vermeer's syndrome versus men 2A, Sippel syndrome. Men, though it is a medicine topic, but from this slide that we are doing, it has been asked at least 12 to 15 times. You need to know men. Men 1, organs affected, PPP, parathyroid, pituitary, pancreas. PPP, parathyroid, pituitary, pancreas, versus men 2A, organs affected, ATP, adrenal, which shows pheochromocytoma, thyroid, which is associated with medullary carcinoma, thyroid, medullary carcinoma, and parathyroid hyperplasia. Next, Manan nahi dost, the slide is visible, it's absolutely okay. Next, versus men 2B, where organs affected are AT, adrenal, pheochromocytoma, thyroid. Zoom it out. Okay, I guess this will be slightly better. Men 2B, adrenal, pheochromocytoma, thyroid, medullary carcinoma, thyroid. So organs affected. First point, men 1, it is associated with menin, which is a tumor suppressor gene. Menin, tumor suppressor gene mutations. Menin, tumor suppressor gene, which is present on chromosome 11. Versus men 2, both men 2A / men 2B, both which is associated with RET, that is a proto-oncogene. Present on chromosome 10. You very well know there are 2 types of genes. Proto-oncogene, activation of which causes cancer. Inactivation of tumor suppressor gene causes cancer. So men 1, menin, men 2, RET, both 2A, 2B, RET proto-oncogene, chromosome 10. I know dopamine kuch bhi nahi hai dost. The first line is just, I have just written men 1, 2A, 2B. Nothing else is written other than that. What you are able to see, it starts from here. I'll write the first line below. This is men 1, men 2A, men 2B. Now the first line is also there. Next, ZD syndrome, Zolliger-Ellison syndrome. ZD syndrome, that is Zolliger-Ellison syndrome, is associated with men 1. Men 1, the organs were PPP, parathyroid, pituitary, pancreas. So the question that is asked is ZD syndrome, which is the most common site of gastrinoma. Most common site of gastrinoma is duodenum. Please don't mark it as pancreas. It is duodenum. In ZD syndrome, Zolliger-Ellison syndrome, gastrinomas occur in triangle of Passaro. Triangle of Passaro, you know that in duodenum, this is pancreas. Head of pancreas is present in the lap of duodenum. So this is the triangle of Passaro. The base being the second part of duodenum, apex being head of pancreas. Here gastrinoma, this is the gastrinoma triangle. So gastrinomas most commonly occur in duodenum. Therapy of choice in ZD syndrome, surgery, surgical removal of gastrinoma. Drug of choice being PPIs, proton pump inhibitors. First class bache. This was with respect to men syndromes. This was men. Next question. This gets us to lungs. Now again, the minute we see this, you are clearly able to make out that all these are the thin-walled alveolar septa with air inside it. These are the alveolar septa with air, making this as nice normal lungs. This is irreversible dilatation of the acinus. That is emphysema. So diagnosis, emphysema. Next, the 3 C's of asthma. Next, what you see here, examiner just told you that this is a sputum sample. You are able to appreciate the presence of thick mucus plugs in a background of mucus. Kirschmann spirals. The 3 C's of asthma. Kirschmann spirals, charcoal-laden crystals, which are composed of eosinophilic protein called as galectin-10. Composed of eosinophilic protein called as galectin-10 and Crayola bodies. This is asthma. Next, a very, very important image. I want you to tell me this 1, 2, 3, 4. We were just having face-to-face crash course in our LNX program, and in the face-to-face crash course, majority of the students went wrong in this. So I want you to tell me 1, 2, 3, 4. Dekho bache, you are able to see the presence of which color? These are fibers which are coated with which color? Brown. Which pigment is brown in color? Hemosiderin. Hemosiderin coated asbestos fibers. Hemosiderin coated asbestos fibers called as ferruginous bodies seen in asbestosis, called as ferruginous bodies. Very nice. Which are the 2 malignancies associated with asbestosis? Asbestosis, it is associated with both adenocarcinoma lung and mesothelioma. Most common malignancy, it is associated with adenocarcinoma lung and mesothelioma. Most common being adenocarcinoma lung, most specific being mesothelioma. It has a long latency period of 10 to 30 years, mesothelioma. It's very rare, has a poor prognosis, has a long latency period of 10 to 30 years. This is mesothelioma. Next, diagnosis. TB has caseous necrosis. Now, suppose a question is given, non-caseating granulomas with bilateral hilar lymphadenopathy, sarcoidosis. Sarcoidosis microscopically shows non-caseating granulomas with bilateral hilar lymphadenopathy, asteroid bodies and Schumann bodies. Asteroids, they are the stars which are falling from the sky. So it is a giant cell. You know it's a giant cell, it has multiple nuclei with presence of star-shaped inclusions. Star-shaped inclusions in giant cells called as asteroid bodies seen in asbestosis. Next, see, this was a recent FMG image. This was already asked. This, I need not tell you, is a Langerhans giant cell. Langerhans giant cell, giving it the horseshoe-shaped appearance with granulomas. With all this pink are the granulomas. These are the granulomas seen in TB. TB is examiner's favorite question. TB has been asked. Last year FMG exam, they gave you image of granuloma in GIT and asked you that the main cell associated is macrophage. Main cell is macrophage. Which are the cytokines associated? Acute or chronic? The chronic cytokines, which are interleukin 2, 12 and interferon gamma. It is associated with chronic cytokines. TB, type 4 hypersensitivity, cell mediated or the delayed type. This is a favorite question. So if he wants to go a step further, he will ask about sarcoidosis. Please don't go wrong in this. Next. This gets us to our next important topic, myocardial infarction. Again, previous 2-3 papers, you had 1 question each from MI. Now, all of us have held heart in our hands during anatomy, I guess. Girls, they hold it more often, I guess. But when we hold heart, it has a different feel. You know, it has 3 layers, endocardium, myocardium, epicardium. The blood supply is from the outside, that is from epicardial vessel. So first point, which is the least perfused area in the heart? Least perfused area is just below the endocardium, that is subendocardial region. Least perfused area, subendocardial region. After ischemia, after the blood supply is reduced, ATP starts reducing within seconds. ATP becomes 40% of normal in 10 minutes, 10% of normal in 40 minutes. This is a 10-40 rule. Irreversible damage to the heart is 20 to 40 minutes with an average of half an hour. If both 20 and 40 are given in the options, we will mark it as 20 minutes. We'll mark it as 20 minutes because in some people irreversible damage occurred at 20 minutes also. Next, this irreversible damage can be seen by three techniques: electron microscopy, light microscopy, Gauss. First to be seen, electron microscopy, which shows the presence of amorphous densities in mitochondria. Time period of this change being half an hour. That is how we know that at half an hour there is irreversible damage. Whereas the first change seen on light microscopy is waviness of cardiac fibers. Cardiac fibers become wavy in nature. Time period half an hour to 4 hours. Versus Gauss, the first Gauss change is dark mottling. We see the presence of black spots on the heart, काले धब्बे पड़ जाते हैं, dark mottling, which start appearing at 2 to 4 hours but is visible after 12 hours. They start appearing at 2 to 4 hours but are visible after 12 hours. So, this time's December FMG question, for early visualization of Gauss, we use TTC staining of the heart. This is a cut section of the heart. We use TTC, triphenyl tetrazolium chloride, TTC staining of the heart, which shows the Gauss change at 2 to 4 hours. See, anterior, posterior. In pathology, we keep anterior below, posterior on top. Radio people do it the other way around. They keep spine below, not concerned. Anterior, posterior, this is left, this is right. So, what is the site of ischemia? Posterolateral, TTC staining of the heart. This is Gauss. And lastly, microscopically, that is pattern of light microscopic changes in MI. First change is waviness of cardiac fibers, which is associated with damage, neutrophilic infiltration, necrosis. Now damage has occurred, healing, macrophage activation and phagocytosis, granulation tissue formation and scarring. Time period, waviness half an hour to 4 hours. Waviness of cardiac fibers, time period half an hour to 4 hours. Neutrophilic infiltration and necrosis begins at 4 to 12 hours, but peaks at 1 to 3 days. Macrophage activation and phagocytosis, 3 to 7 days. Early granulation tissue formation, 7 to 10 days. And lastly is scarring. It begins at 2 weeks but is completed by 2 months. 2 weeks but is completed by 2 months. This is time period changes of MI. This is myocardial infarction. This is MI. And microscopically, देखो बच्चे, the minute we see this, what do we see here? This is normal cardiac muscle. On the left, we have waviness. We have waviness of cardiac fibers. That is time period associated half an hour to 4 hours. Next point. Just a sec. Next point. Now have a look at our next image. That is, have a look at this now. What do we say here? All these are neutrophils with necrosis. All this is neutrophilic infiltration with necrosis. Time period 1 to 3 days. This is MI, myocardial infarction. This is MI. Next question. This gets us to our next important topic in heart, that is vegetative endocarditis. देखो, there are 4 vegetative endocarditis: RHD, rheumatic heart disease, infective endocarditis, NBT, and SLE affecting the heart, that is Lippmann sac. In the first 3, RHD, infective endocarditis, and NBT, most common valve affected is mitral, followed by aortic. That is, they affect left side of the heart. Versus Lippmann sac endocarditis, where most common valve affected is mitral, followed by tricuspid valve. Mitral followed by tricuspid. So, mitral followed by tricuspid, I can safely say Lippmann sac affects atrioventricular valves. I can safely say it affects atrioventricular valves. Lippmann sac. It has vegetations on both sides. Vegetations are present on both sides of the heart wall, more common on lower surface. They are on both sides, more common on lower surface. Liebman-Sack endocarditis. Fibrinoid necrosis is seen in RHD and LAC, that is RHD and SLE affecting the heart, fibrinoid necrosis. RHD, which is the criteria used to make a diagnosis? Jones criteria, modified Jones criteria. What is the diagnostic hallmark of RHD? A very important image. RHD, diagnostic hallmark is the presence of ash of bodies. It is ash of bodies, which is focal inflammation in the heart. We are able to see the normal heart muscle, normal cardiac muscle on the side, focal inflammation in the heart, ash of body, seen in RHD, The pathognomic cell or the diagnostic cell of RHD being, there are many inflammatory cells, ash of giant cells, macrophages, T cells, but the diagnostic cell being Entishkow cell. Diagnostic cell being Entishkow cell, also called as caterpillar cells. This is RHD. Acute RHD is associated with mitral regurgitation versus chronic RHD, mitral stenosis. Mitral stenosis in turn gives it the classical fish mouth valve appearance. Mitral stenosis. The mitral valve is stenosed, in turn giving it fish mouth valve appearance. RHD, rheumatic heart disease, RHD. It occurs after group A beta hemolytic streptococcal infection. Point to be seen is, it is not an infective etiology. Streptococcal infection occurred. Antibodies against M protein of streptococcal infection cross-react with host antigens. So what is the pathogenesis of RHD? Molecular mimicry. Pathogenesis of RHD being molecular mimicry. It is which hypersensitivity? Antibody-mediated hypersensitivity, that is type 2, RHD. And lastly, bache, this gets us to our last image for today's session, that is diagnosis. The minute we see this, I am clearly able to make out that it shows the presence of very large vegetations. It has large friable vegetations, infective endocarditis, i.e. infective endocarditis, i.e. Done. So this absolutely takes care, guys, something is going wrong in this, but thankfully this is the last slide. So I guess this takes care of our rapid revision in pathology. Needless to say, bache, bestest of luck for the paper, do extremely well. Shifali, bache, molecular mimicry is, child got streptococcal infection in RHD, antibodies against M protein of streptococcal infection, they cross react with host antigens. गुस्सा किसी पे था, निकाल किसी और पे दिया. Antibody was against M protein of streptococcal antigen, but they react against host antigens. This is molecular mimicry, antibody mediated hypersensitivity type 2. Bestest of luck, friends. All of you are going to pass. Keep confidence on yourself. Keep on revising. Don't miss out on any subject. 2 revisions, go and give the paper, you will get through. Take care and bestest of luck from bottom of my heart.